In Scientific Dialogue with, the Women and Infants Research Foundation's podcast series celebrating the pioneers shaping the future of women's maternal and newborn health. This series spotlights incredible individuals driving innovation, medical researchers, clinicians, nurses, midwives, and other professionals in allied health. Each episode's guest will discuss their innovative work and how it may transform maternal care and clinical practices, from improving preterm birth outcomes, maternal mental health, gynaecology, and more. So sit back and join us in Scientific Dialogue with. Welcome to episode 1 of In Scientific Dialogue with WIRF podcast. I'm your host, Vicki Main. This month I'm joined by Dr. Sean Carter, a John Monash Scholar and RANZCOG Senior Registrar in Obstetrics and Gynaecology at King Edward Memorial Hospital in Perth. He's currently completing a PhD at the National University of Singapore, researching the molecular and pharmacological basis of fetal lung maturation to improve antenatal corticosteroid therapy and the management of preterm birth. Sean has co-authored numerous peer-reviewed publications, holds several international research grants and scholarships, and has received multiple awards for his conference presentations. Outside of research, he enjoys hiking, surfing, and sharing a whiskey or two with his PhD supervisor, Professor Matt Kemp. Welcome, Dr. Carter. May I call you Sean?
Yeah, thank you very much, Vicki.
Can you share your journey into women's health research and what inspired you to pursue obstetrics and gynaecology?
My journey into women's health and research began about 15 years ago when I was a third-year medical student at the University of Western Australia, and part of my medical school training was I needed a research project. I'd never really been exposed to much research at all, and particularly so with regards to women's health, but I was quite fortunate that through some friends, I got introduced to the WIRF team, the Women's and Infants Research Foundation team, and in particular, Matthew Kemp, who's, of course, the current scientific director of WIRF and a professor up in Singapore. But back then, he was a rather scruffy postdoctoral senior research fellow in the lab, and we quite quickly struck up a close friendship, which has continued for the last 15 years. And he took me under his wing and invited me to join the research that year. And so the next thing I really knew was I was walking into a corrugated iron sheep shed on a cold July winter's morning here in Perth. And I was standing at an operating table learning to do a cesarean section for the first time on a sheep and deliver a preterm lamb. And from that moment on, really, this amazing research team, I got really passionate and enthusiastic about women's and infants research, and particularly, of course, preterm birth research, and could see the translation from really what we were doing in that lab and in that sheep shed to really impactful research to try and change outcomes for preterm babies worldwide. And so that really led me to try and join the team at every opportunity I could. So every year I would take some time away from medical school or my clinical training and come and join the team here at WIRF to continue some of that research. And that eventually led me to undertake a PhD up in Singapore at the National University under the supervision of Prof. Matthew Kemp, and with the help of a John Monash scholarship. So that's really how I ended up falling into women's research and preterm birth research in particular. But it really was about the special team, the enthusiasm, the passion, and how translatable that research was that really drew me in. From a clinical perspective, of course, I started to get interested in women's health from doing the research and having some really close mentorships with some leaders in the field in obstetrics and gynaecology through that those connections. I did a couple of years of adult medicine and surgery and intensive care here in Perth before coming across to King Edward Memorial Hospital, which is the only tertiary centre for women's health in Western Australia. And it was almost immediate that as I sort of got to know the team, that I felt like I'd met my tribe, I'd met my people, and knew from really quite quickly on that this was the specialty for me. For a number of different reasons, obstetrics and gynecology became my area of interest. It's a really unique area of medicine where our outcomes that we aim for, particularly in obstetrics, of course, are joy. And that's quite different to a lot of other areas of medicine that deal with, relieving pain or treating chronic disease. So it was that really interesting aspect to the work that we were doing. The other thing I loved about it is that every single day is different in the life of an obstetrician gynecologist. One day I can be sitting in clinic doing medicine, the next, or even that afternoon, we can be doing surgery and operating, or doing ultrasound, so radiology, as well as dealing with a lot of critical care and very unwell patients. But a lot of it as well is dealing with patients that don't have disease. They're young, fit and healthy, but they are pregnant. So that's a really nice area of medicine that I like about it. It's also very patient-centered. So the decision-making process is very much around having discussions and educating patients and us coming up with a plan together, which I really enjoy about this specialty. And of course, we work in teams, so you're never really alone in obstetrics and gynecology. We have great working environments where the work is all to do with other members of other specialty teams and experts in their own fields, like midwifery and nursing staff. And that's quite unique to obstetrics in particular. So that really special connection that we have, particularly with midwives, is something that I really, really enjoy. And some of my best friends are the midwives here at King Eddie's that have really taught me most of what I know through my training. There's another aspect to obstetrics, particularly on labour ward, that I enjoy, which is actually, it sounds a bit odd, but somewhat a lack of control. So you really don't know what's coming through the door every day, and that leads to a lot of excitement and a lot of adrenaline, which is actually really quite fun. Makes for a fun workplace, especially with that team environment. So I'm very lucky to love my job, and no matter what kind of day I've had before, or what kind of night I've had before, I always enjoy coming back into the hospital every day. So I'm very privileged to be able to have that.
Fantastic. So with approximately 15 million preterm babies born globally each year, and 1 in 10 babies are born preterm worldwide, what do you see as the most critical challenges in tackling preterm birth, both globally and regionally?
Yeah, look, preterm birth, it's staggering, those numbers. For anyone listening, preterm birth is when a baby's born too early or before 37 completed weeks of gestation. And depending on where you are in the world, that can be down to really the limits of viability, and that changes. But here at King Edward's, that's around 22, 23 weeks, depending on some factors. So this is a global health issue, and unfortunately, those numbers are probably from about 10 or 15 years ago, and they're only continue to rise. So even more babies are born prematurely every day around the world. And this is a disease that affects everyone. It's indiscriminate, but it certainly, unfortunately, affects the most vulnerable patients in our communities more so. So it's a really terrible disease. It's still the leading cause of death and disability for children under 5 worldwide, and that's not changing. There are lots of challenges around the management and the prevention of preterm birth. And this speaks to women's health in general, is that we know so little around preterm birth. But one of the challenges is that we don't understand normal labour at term, which is, I think, as an obstetrician, shocking, that we don't understand a normal process that every pregnant patient will go through. We have some ideas around labour and how that's initiated, but we don't fully understand the mechanisms in women. And so when you don't understand normal, it's extremely difficult to understand a disease process or a pathology like preterm birth because we have no normal to compare it to. The other issue with preterm birth is it's the end result of a number of different conditions. So really it is an umbrella term for lots of different diseases in pregnancy that end up leading to premature birth. So we're not just dealing with one condition here, we're dealing with multiple. And that makes it obviously more difficult to treat. Really, I think this is unfortunately about overall, there's a gross or underrepresentation of women's health and women's health research in the literature and in public awareness. And I think that's actually the greatest challenge that we have is that lack of research, that lack of awareness, and that lack of funding for women's health research. And that's what we need more of. That's how we need to tackle this problem, is that we need more awareness, we need more research, and to be able to do that, we need more funding. So overall, I think these are some of the general ways in which we can try and tackle this.
Thank you for your insights there. So how does your research contribute to addressing these issues on both a local and global scale?
So our team, and particularly my PhD, is focusing on one of the main treatments that we give to women at risk of preterm birth, being antenatal steroids. So any woman that comes in that's at risk of preterm birth around the world will be administered these drugs. And they primarily work by maturing the fetal lung. The biggest hurdle that preemie babies have to life is breathing because their lungs are too stiff. They can't perform gas exchange, so these babies really struggle to breathe. So we've known for the last 50 years or so that antenatal steroids improve breathing, and because of that, they improve survival. So, however, despite using these drugs for 50 years, we are increasingly finding that there's many potential issues with antenatal steroids. Firstly, no one around the world, despite 50 years of use, can agree on the drug to use, the way or the dosage of which drug we use, and the way that we give it in the particular regime, which is pretty surprising because these are some of the most widely prescribed drugs in pregnancy.
Wow.
Yeah. So part of our research is trying to address that issue in terms of which drug we should use and which dose and regime we should use. The other aspects to our research is starting to investigate some of the off-target or adverse effects of these drugs, particularly on other organs. So obviously we're using these drugs to mature the lung, but we are increasingly finding that these drugs affect every single other developing organ in the fetus. And some of them are particularly troubling, particularly with regards to brain development and things like that. So part of my research is about optimizing this important therapy. We know these drugs are great benefit when they're given to the right patient at the right time, but we're trying to improve how they're given and to which patients they're given to. And really trying to understand how these drugs work on a molecular basis, because hopefully in the future we can understand that better and come up with more targeted therapies to improve the outcome, so the benefits from these drugs in terms of survival and lung maturation, but without some of those off-target, potentially damaging effects.
Thank you. That's fascinating. How have your experiences at King Edward Memorial Hospital shaped your research in this area?
Yeah, well, so King Edward's is as I said, the only tertiary unit right now in Western Australia. And what that means is that all women at risk of having extreme preterm birth, particularly under 30 weeks or particularly under 28 weeks, will be transferred to King Edward's from around the state. So that can be as far as, Broome, Kununurra, or further south as Esperance, or even further. So we have a centralisation of all of these women at risk of extreme preterm birth. And from that we do all of these difficult extreme preterm deliveries. So as a trainee, you get unfortunately, well, whichever way you look at it, you get a large amount of experience in dealing with preterm birth. And that has an effect. So, it's not uncommon to be having to do an emergency cesarean section on a patient at King Edward's that's 23 or 24 or 25 weeks, and delivering babies that fit in the palm of your hand, that are see-through, that are not breathing, and delivering that baby and handing it to our colleagues, the neonatologists that are in the operating room, right behind you. It's an interesting situation, that operating room. We turn the heat up because these babies can't control their temperature. So it's very, very hot in that operating room. And when there's a lot of people there, obviously there's midwifery, nursing staff, multiple neonatologists, and of course the obstetric team and the anaesthetists. So there's a lot of people there. And when we deliver these babies, we hand them to the neonatologists, and you can hear them behind you working on these babies on the neonatal cots, as we still have to operate and take care of the mother. And that's a really emotional experience, hearing these things in the background and trying to resuscitate these babies as you're still having to operate on a mother. It's then that, after the operation, that we go and see the families and we counsel them as a team, and just seeing the impacts of that extreme preterm birth, and really most preterm birth has on patients, on families, was a huge motivation for me to try and change this disease and the outcomes that we have for preemie babies.
You're currently completing your PhD at the National University of Singapore on the optimization of antenatal steroids. Can you tell us more about these drugs and what they are used for, and what challenges remain in addressing the long-term health of preterm infants?
Yeah, absolutely. So firstly, one of the biggest hurdles to life that premature babies face is breathing, because their lungs are too immature. They're too stiff, and they're not mature enough to undertake gas exchange. So luckily, we have a treatment that we give to any woman or any woman that is at risk of preterm birth around the world, in antenatal steroids. And these are drugs that were first discovered, back in the 70s in New Zealand. And we know from a lot of clinical trials that over the last 50 years, these drugs work very well to mature the fetal lung. And because of that, they improve that baby's ability to breathe, and then therefore survival. It's really interesting, though, that despite 50 years of clinical use, no one around the world can decide on which is the best antenatal steroid to use. So there's a number of different drugs that come under the term antenatal steroids. We don't know which is the best dose to use, and which is the best regime to use. So there's a lot of wide variation around the use of these drugs, despite them being one of the most commonly used drugs in obstetric practice around the world. So that's one of the sort of interesting things in which we are trying to look at, advising and discovering or investigating what is the best drug and what is the best or the safest dosage to use. The other issue with these drugs is that in obstetric practice, we are not, unfortunately, very good at deciding which women are at risk of preterm birth and are going to then go on and deliver preterm, versus those that might come into hospital contracting or with ruptured membranes and we think are at risk of preterm birth, but actually stay pregnant up until term. So if you look at the trials, we actually get this wrong about half or up to half of the time. And so in that case, we're potentially exposing women, or up to half of the women at risk of preterm birth, of giving them steroids with no real benefit. And that's an issue because we're increasingly finding with steroids that there are many off-target potentially adverse effects from these drugs. So we know that they work very well when given to the right patient at the right time in terms of improving survival and lung maturation. But we also are increasingly finding that there is some off-target effects on particularly things like brain development that we really need to understand further and have some more nuanced discussions around with patients before we give these. So a lot of our research is looking into some of those aspects.
Yeah, can you tell us a bit more about how your research might contribute to the developing more targeted, safer antenatal steroid treatment protocols for preterm births?
Yeah, absolutely. So part of my research is looking at how these drugs work on a cellular level and a molecular level, which is sort of surprising because, as I said, we've been giving these drugs for 50 years and we don't understand really on a deep level how they work to mature the fetal lung. So part of our research is trying to do that, to try and do a deep dive into how they work on a cellular level so that we can understand and then hopefully in the future come up with a targeted therapy that only matures the lung but doesn't have some of these off-target effects. So that's some of the work that we are quite excited about and looking forward to completing into the future.
Yeah, thank you. And you recently published a paper investigating the use of antenatal steroids in Singapore. Can you tell us more about this research?
Yeah, so Singapore is a great place to do research. It's a great place to eat pepper crab and drink ice cold tiger beers. But it's really interesting to study steroids there because they have as a nation a very unique dose of antenatal steroids that they give to women there. It's a quite high dose compared to other areas of the world. Given over a relatively short duration compared to places like Australia and New Zealand. That regime's never been studied in large clinical trials. So we undertook a study investigating that and were interestingly able to show that the particular antenatal steroid that they use, dexamethasone, is potentially not as effective at maturing the fetal lung as the drug of choice that we use in Australia, which is betamethasone, at that dose that they're using. So in this paper, we were able to show that a reduced dose of antenatal steroids, and particularly using betamethasone rather than dexamethasone, may be best for lung maturation. But we also looked at brain development and we were able to show that, again, a lower dose of betamethasone used in Australia is potentially much safer for brain development and neurodevelopment for these preterm babies, as opposed to the very high dose of dexamethasone that they were using in Singapore today.
Wow, that's fascinating. And what has been the wider research community's response to your findings on antenatal steroids, and particularly regarding the long-term risks?
Yeah, so medicine is always slow to change. So there was a lot of talk about this paper when it came out in Singapore. But I'm very pleased to say that there has been a lot of enthusiasm about changing the way that they're giving antenatal steroids in Singapore as a result of this paper. And that's led to another paper that we've written as a consensus statement on changing these drugs and the way in which they're given in Singapore to be more in line with a lot of the rest of the world, in particular with Australia and New Zealand. So we're very pleased to be able to say that it looks like there will be a drug change and a dose change in Singapore to potentially a more effective and safer regime of antenatal steroids used there.
Brilliant, brilliant work. Well done.
Thank you.
Well done, you. Following on from this, I understand that you've recently developed a maternal blood test to predict fetal lung maturation. Can you tell us more about the important study and how it might be used clinically?
Yeah, so as I was saying, one of the issues with antenatal steroids is that we often expose, up to half of the women that we think are at risk of preterm birth to steroids when they don't need it. And we know that these drugs work less effectively the closer you get to term. So the benefits really drop off after sort of 34, 35 weeks of gestation. And that's, presumably because of a lot of these babies already have mature lungs at that gestation. So there really isn't a great deal of benefit, we would argue, in those late preterm births, sort of over 34, 35 weeks. But unfortunately, in clinical practice, we don't have any minimally invasive or non-invasive way of deciding whether or not a baby has mature lungs or not when they're still in utero. And because of that, we wanted to develop a minimally invasive or blood test, a maternal blood test, that could predict fetal lung maturation and give us some understanding about that, so that we could then use that result to decide whether or not a particular patient needed steroids or not. So really, we're trying to use this to optimize patient selection for steroids. This test, in some ways, is a biomarker into the womb. So it gives us information about how a baby is maturing, particularly, of course, lung maturation. So it's a new sort of, it's a new window into intrauterine development. And hopefully we can develop more tests that are looking at other organ development. So it doesn't have to just necessarily be about lungs, but we can also look at other organ development depending on the situation.
Moving on to intrauterine infections, these are the leading cause of preterm birth. And can you share more about this and how, with regard to your research, what role do early inflammatory markers play in the timely detection and prevention of this condition, and how might these findings inform current clinical practices?
Yeah, sure. So intrauterine infection and inflammation, or chorioamnionitis, as you said, is a leading cause of preterm birth. So naturally, we got quite interested in looking at this condition. And it's very interesting when you look at the current clinical tests for how we decide whether or not a patient has intrauterine infection and inflammation. They actually perform really, really poorly. So we're not good at actually deciding which patient has this condition and which patients don't. A lot of the criteria that we use currently rely on things like a mother's temperature going up, or her respiratory rate, so how quickly she's breathing, or her heart rate, so the maternal heart rate or even the fetal heart rate. And a lot of these things can go up for reasons that aren't related to infection or inflammation. So really, we don't have good markers at present. Even blood tests are not very accurate in diagnosing this condition. And the best treatment that we have, or sorry, best test that we have, is amniocentesis, which involves putting a needle into the abdomen, which is obviously quite invasive and can be potentially painful, obviously, to the patient, which is not often done. And there's a number of issues around not having a good test for intrauterine inflammation and infection. One is that we don't have good treatments for this condition. So if we suspect it, the only thing that we can do is administer antibiotics rapidly to the mother and then precipitate an urgent delivery of the fetus. Because if this baby is infected, we know that this can lead to brain damage. So the only treatment we have is delivering. The problem is, if we don't have a good test, we often deliver babies incorrectly, potentially, that don't have infection, and we expose them and the mother to antibiotics. The flip side as well is that we often miss babies that have infection. And that's a subclinical infection, so we don't see it until that baby is very, very unwell. So there's a missed opportunity there. So we got interested in trying to improve these tests to increase the accuracy, so that we could pick the babies that do need delivery and treatment, as opposed to those babies that we can potentially monitor and avoid delivery.
Yeah, that's fantastic. And I know when I was doing my own background research into the whole notion of intrauterine infections, it seems that there was, things like, as you mentioned, brain damage, sepsis, and cerebral palsy, and there was various knock-on effects of these things. So it's such important, the research that you're doing, Sean, in this area. It's fantastic. Given the significant neonatal risks associated with chorioamniotesis, such as brain disease and sepsis, how does your research into early detection and inflammation aim to improve neonatal care strategies, particularly for extremely preterm infants?
Yeah, so following on from what I was talking about, the way that we're trying to improve the diagnostic accuracy of these tests is by developing maternal blood tests that look at what we call cell-free RNA. So RNA is something that tells us in real time what's happening with cells and how they're responding to stimulus such as infections and inflammation. So we've been able to utilize this technology to develop a test that is highly accurate and much more accurate than the current clinical criteria that we use in the hospital or the current blood tests that we use in the hospitals to diagnose chorioamnionitis. And we're able to detect babies that have very, very early on infection and inflammation, much earlier than the current test that we have. And this gives us a lot of benefits in terms of ability to give antibiotics early to the mother to try and treat the infection and the inflammation, and then delivery if we need to. As I also said, the benefit from this new test is that it can tell us if there isn't inflammation occurring in utero very, very accurately, so that we have more information about what's happening within the womb, and we can maybe hold off on antibiotics or indeed hold off on delivering a potentially very extreme preterm infant. And that allows them obviously to develop further and hopefully improve outcomes.
So how have international collaborations, such as your work at the National University of Singapore and Toyoko University, advanced maternal and neonatal health, particularly in addressing complex issues like the long-term effects of antenatal steroid use?
Yeah, well, research is really interesting because I think it's the closest thing to competitive sports. So it's a really highly competitive environment, and you work in teams, and you're competing against other teams around the world that are often investigating similar things, and you're competing for things like publications, for grant funding, and for presentations at conferences and things like that. Part of that, though, is choosing teams to collaborate with. And this is all really about teamwork. And so we've been very, very fortunate to have some really highly productive and really great and fun relationships with different teams around the world, particularly with Tohoku University in Sendai, Japan. That's been a really long-standing and really incredible relationship. Of course, as well with the National University of Singapore. And this leads us to be more competitive on a sort of global scale. And that means that we can do things that we can't do alone. We also have the benefit of bringing experts from around the world and these different teams together each year to brainstorm, to come up with new ideas. And we often see the same problem with a very different lens and a very different way of attacking that problem. So I think it's one of the most crucial things to being a productive and competitive research team is having these collaborations. It's also just a wonderful thing from a social perspective, in that I've got so many great and very, very close friends around the world now that I get to go and travel and visit. And there's a lot of fun that goes along with that in terms of eating and drinking and travel. So for many different reasons, those international collaborations are just key to the success of this team.
Yeah, fantastic. And would you say snowboarding or skiing in Japan?
Look, I'm a diehard snowboarder, so
Oh, okay.
and was very lucky to have a trip with one of our colleagues, Harry Yasuda, who is from Tohoku University originally, but's been down here at WIRF for a number of years. So he took me on a very special sake and snowboarding trip recently. So one of the
Fantastic.
many benefits of that collaboration.
Sounds like fun. I'll have to get some snowboarding tips. So balancing clinical responsibilities with research can be demanding. And how do you manage this dual role? And what strategies help you continue making impactful contributions, especially in preterm birth prevention and neonatal health?
Yeah, well, look, you can't do this alone. So the best strategy that I have and we have as a team is teamwork. And we are very fortunate to have a quite unique team in that we have a really even mix almost of clinicians and scientists. And so when, as a clinician, I need to go and do clinical work in the hospital, the team is able to help me out with lab work and things like that. I would say that there are times when there isn't much balance to that, and there are times during your training where you need to just be a clinician. So a lot of my time has been doing my clinical specialist training, but then stepping away from that to be a researcher. So really for the last 3 years, I've been full-time researching and coming back and doing casual work to keep my clinical skills up. But right now, there hasn't been, I suppose, a balance, but that's been because I needed to learn some key skills to allow me in the future to be a clinician scientist. And so hopefully in the future, there will be much more balance in terms of being able to do clinical work in the hospital for a few days and then the rest of the week or for 2 or 3 days of the week doing research. But I'm only able to do that with the team, basically. And that's the biggest thing.
What advice would you offer to young researchers or medical students passionate about maternal and neonatal health, particularly those interested in studying the long-term impacts of interventions like antenatal steroids?
Yeah, look, firstly, there's just so many benefits for myself being a clinician scientist. It's taught me a completely different way of thinking. A lot of medicine is quite black and white and quite dry, and you're doing things that other people have discovered many, many years ago, and you're following guidelines. So there's actually not that much creativity in that thinking, and that's what I've really learned and loved and has been really difficult, but exciting, is learning a new way to think and being creative. So I'd say that this is a unique thing about research is that you get to creatively think, and that's was quite interesting for me that you're doing science, but you're really creative. The other thing is, as I've said throughout this podcast, you get to travel so much and you develop so many special relationships and get exposed to so many different cultures through research. And that's been such a special thing for me. So I'd highly recommend, if you're interested in travel, if you're interested in different cultures and food and drink, but also if you're interested in something that's competitive, the research is a great career for that. And a lot of the people in our team used to be fairly high level sports people in their own right before coming into research. So kind of have that interesting appeal to it. I'd also say that from a clinician scientist perspective, it gives you a lot of long-term balance and longevity in your career. A mentor once said to me, you should cut when you're young and talk when you're old. And I think there's a lot to that. I will not have to be standing at an operating table when I'm 60. I can talk and advise. And I think that's a really nice aspect to it. Going on with that, I love the aspect of teaching and helping juniors in the team. And that's a really rewarding aspect to this work that I find just gets more and more attractive the more experienced you get. So it's a great aspect to this career. It's a career that is exciting, you know, and I'd highly recommend it. I would say to any budding junior scientist or clinician that there's a few really important things that you should consider when you're going into this career, and that is find an area that you're passionate about, because that's really important, particularly when you're taking on a PhD. There's often late nights and weekends that you're doing your research, and if you're not passionate about it, that's going to be a bit of a tough journey. I'd also say, secondly, that probably the most important person in your life when you're doing your PhD and doing science is your research supervisor. So choose wisely. It's probably more important than your partner at times. And I've been very lucky to have a very close friend in Prof. Matthew Kemp, sort of guide me through that process. So that's absolutely key. I'd also recommend finding an area that's translatable. So as I said, what we do a lot is take things from the bench side to the bedside. And that, as a clinician, I find really, really exciting because you can see the impact of your work in a very translatable or translatable way. So that's really nice to see. And I would say that, you don't need to have particular skills to get into this field. You just have to have enthusiasm. I can remember when I started my PhD, I couldn't pipette at all. I had no skills basically. And Matt had me up in the lab pipetting water for 3 days. So, enthusiasm goes a long way. We can teach you any skills that you really need. Yeah.
That's wonderful.
And yeah, come and join us. We need more women's health researchers. So our door is always open. Please come and have a chat to us.
Wonderful. Thank you, Sean, for sharing your insights. So what's next for you? Can you share a bit more about your career and life goals moving forward?
Yeah, so I've just moved back from Singapore after sort of 3 years up there, and over the next couple of months we'll hopefully complete my PhD and then return to full-time clinical work at King Edward Memorial Hospital. I'm hoping to take on some subspecialty training in maternal fetal medicine, so helping to care for the most at-risk pregnancies. And as I said, when I'm returning to clinical work, we'll definitely be continuing the research with the help of our team here at WIRF. So over the next 5 years, I'll be working clinically, but also undertaking preterm birth research, particularly around antenatal steroids. And then long-term, would love to have a position in a tertiary centre for women's health like King Edward Memorial, and spend some time working at an academic institution or university doing the research and really performing that translatable research that we do with this team.
Thanks a lot, Sean, for joining us. You're an inspirational man, and thank you for everything you're doing in the space within women and infants health research and clinical work as well. Thank you.
Thank you very much, Vicky. It's been great fun.
Cheers. Thank you.
If you'd like to learn more about WIRF or explore opportunities to get involved in future fundraising efforts, be sure to check out the link in the show notes. Additionally, if you're a researcher, obstetrician, gynaecologist, clinician, nurse or midwife working in women's health in Western Australia, don't miss the In Scientific Dialogue event on Friday the 5th of September. We'd love to see you there.